So there's no standardly accepted blood test that's available as part of the workup and evaluation for IPF. There's not a test you can do that says whether you do or don't have IPF. There are a few things that are promising, which is really interesting, I think. There's this KL6, about 19 out of 20 with people with pulmonary fibrosis, this test will be positive and it's specific for it. So it has a lot of promise, but it's not commercially available yet. There are a variety of others that are being tested, but are not out yet. And then there are a lot of things that commonly are drawn, like markers of inflammation or protein levels, things like that, but they just aren't widely accepted because it's not known how they're going to really change management. If the blood test is drawn and it says you have some inflammation in your blood, a lot of people do. They're not specific tests to help. Arterial blood gas testing is often used. How many people have had arterial blood gases drawn from the radial artery? It's a tough test. You want someone who's done a lot of them to do it. It's not as comfortable as a venous draw. But it can be really important to see how oxygen's getting in and carbon dioxide is getting out. So after all that, I tell you that IPF stands for idiopathic. So what causes it? And that's just the thing. We aren't sure. And I think one of the things that I wanted to show was that there are all these things. Each thing that's up here, there's been a lot of research behind each aspect of that and looking into how much does it contribute to pulmonary fibrosis, and is it the main thing, or is it part of the problem, or what exactly is there? There have been several viruses that have been found to be more likely in people with pulmonary fibrosis than people who don't. And there's always that idea, did a switch turn in my body that changed the immune system from a viral infection that then led to this type of manifestation from it. Environmental pollutants, there have been several that have been associated with the development of idiopathic pulmonary fibrosis. Surprise, New Jersey comes out so good, but it does. Several drugs that have been known to cause problems very, very similar to idiopathic pulmonary fibrosis. I mentioned amiodarone. There's a long list of medications that have been associated with causing pulmonary fibrosis. Genetics, there are some genetic links. There are entire labs, big labs, 20, 30 people whose whole job is just working this lab trying to find genes for pulmonary fibrosis, NIH-funded research. And there's never been anything that just screamed out as the biggest thing. There are clues from genetic research, but they haven't been definitive. Chronic aspiration. How much of pulmonary fibrosis scarring in the lungs is associated with subtle, what we call silent aspiration, where things are swallowed the wrong way. Not necessarily just during eating, but sort of as part of reflux as well. And that's a hot topic sort of across all of pulmonary disease. Pulmonologists talk about this a lot, the role of chronic aspiration, but especially with pulmonary fibrosis. And then smoking. There has been some implication of smoking, not too surprising given that environmental pollutants are also in the balance with this. But there are many, many things that have been implicated, many studies that have been done. And you get the idea that it's not just one thing that's causing idiopathic pulmonary fibrosis, that it may be a condition, like many things in medicine, where it takes sort of multiple hits. Maybe there's a little bit of a genetic tendency. Maybe there's something that was exposed to in the past. Maybe there's a component of something else, and certainly a role for things that aren't yet totally understood. So here's the challenge. Here's, I think, what would be probably a popular view among pulmonologists as to why this has been so evasive to totally know what causes pulmonary fibrosis. So the lungs have a surface area that's about the size of a tennis court. That's big. If you think about it, it's true, but it's very impressive. There are tons of inhaled particles of many, many different varieties that everyone breathes in. We all have different lives. We're exposed to very different inhaled particles. And the immune response to inhaled particles is unique to each person, and it adapts over time. Our immune systems are, I often think of them as armies, that are made to fight things foreign to the body. And they're incredibly adaptable. I don't pretend to understand the complexities of the immune system, but it adapts over time, and that's unique to all of us. So there's not likely one way that people develop pulmonary fibrosis. But with that being said, here's something that's important to see. It's this thing over here. I think it looks like something out of a Van Gogh painting, like an impressionist type of thing. It's a swirl over here. And this is within that interstitium of the lung. If you remember the picture from the beginning, those two air sacs separated by this layer of cells. These are invaders into this interstitium. And we have a term for this type of a picture. It's called the fibroblastic foci. Because these cells, these little purple dots, are the nucleus of the cells that are called fibroblasts. And what they make is scar tissue, fibrosis, fibroblast. So these fibroblasts are sending out this pink collagen-like tissue into the interstitium, and it creates that swirling pattern. This has become really important in pulmonary fibrosis because the fibroblastic foci is thought to be the origin of where idiopathic pulmonary fibrosis starts. So this is sort of a paradigm shift over the last 15 years or so, because 15 years ago, every pulmonologist thought that the way pulmonary fibrosis worked was that you developed inflammation in the lungs. And this inflammation over time turned to scar tissue or fibrosis in the lungs. So that was always the paradigm shift, inflammation and then fibrosis. But this is different. And it's gained acceptance over the last 10 years that you have this fibroblastic foci that then sort of multiplies and creates more fibrosis within the lungs, that this is popping up throughout the lungs, these fibroblastic foci, that's the starting. So it sort of goes into another question that I think really bugs a lot of people. In 2013, why is there no treatment for idiopathic pulmonary fibrosis? You saw the figures at the beginning. This isn't the most common condition in the world, but it's not extremely rare at this time either. How many hits did you say you have a month on your website?
Almost 5,000. So
5,000 hits a month on that website. So it's not, I think, what anyone would be willing to consider an orphan disease or a very rare lung disease. But there's really nothing out there to treat it. And that's very frustrating. And I think a lot of people wonder, well, is it just that there's a lack of interest or what's going on? But it's not necessarily the case. There has been interest in, over time. Many people have been trying to figure out how are we going to tackle this problem. But the first thing was that there was a huge wave of anti-inflammatory medicines that were tried. And that makes sense if you think about how it used to be approached, inflammation and then fibrosis. So everyone thought, well, prednisone is helpful for a lot of different lung conditions. If it's used over time with idiopathic pulmonary fibrosis, you'll quiet that inflammation, you'll prevent the inflammation from becoming fibrosis, people will do better. It makes so much sense that it was the standard of care for many years without a lot of questioning. And when it started coming back with research that it didn't seem to be helping, that it seemed to be harming more than helping, it was so confusing to physicians who long accepted inflammation and fibrosis that it took a long time for physicians to say, okay, we aren't going to treat idiopathic pulmonary fibrosis with steroids over time. Imuran is another anti-inflammatory that was used. As recent as last year, there was a big study. Everyone's probably heard of the New England Journal of Medicine. It's a huge medical journal. And as recently as last year, there was a study that looked at azathioprine and prednisone, and then another medicine that I'll leave out of it because I don't think it's guilty. But they looked at that combination versus placebo. And they found that that combination was harmful, that the placebo group did better. So even in 2012, these studies are just unfolding and becoming relevant. Other anti-inflammatory medicines, just to list a few. But for a long time, that was the focus. So now, we're starting to get into a realm of looking at anti-fibrotic medicines, thinking about that fibroblast. How are we going to attack that cell? How are we going to stop things from progressing and getting worse? So interferon gamma 1b was one of the medicines that was tried throughout the 90s and early 2000s, and it took about 10 years for that story to unfold and become really disappointing in the process, and tons of resources from a pharmaceutical company who was hopeful that they had the first big treatment for this. So before going on, because pulmonary fibrosis is a condition where clinical research is important, because if you don't have a treatment that's out there, then the trials have a lot of importance to them. So I'll just tell you a second, this is boring stuff, but with pulmonary fibrosis it can be really important. Because it's frustrating. When is this stuff going to come out? Why is it taking so long? So how do they work? They have these 3 phases that the FDA requires. A phase 1 is a few patients that are enrolled, trying to see if something is safe for use. It's not necessarily doing a placebo and a treatment arm, but just seeing if it's safe. Everyone gets their medicine. Some phase 2 studies, everyone can receive the medicine, and then some phase 2 studies start to get into, you may be on the placebo, you may be on the medicine. No one's going to know, not the investigator, not the subject who's in the clinical study.